Hi, I am a second year MBBS student, and in this video we are going to learn or discuss that the heart attack which people face in their 40s 50s starts very early in 20s, and we will also understand that disease that develops slowly. Hope you will like the video. Let's understand with a case first. So there is a 55-year-old male who comes to the emergency department of the hospital. His primary symptoms are the crushing chest pain. Now, what do you understand by crushing chest pain? It literally means someone is sitting on your sternum. The pain is so much. So the attending doctor orders or instructs for a ECG, and in his ECG it shows that there is ST elevation and troponin is high. So the doctor says that you have 90 minutes before permanent myocardial damage. Now the question which arises is that what went wrong and why him? So before we start reading about the pathology and pharmacology behind the ischemic heart disease or ISD, there is one interesting point that the heart attack which people experience in the mid-age group, that is 40s, 50s, 60s, it does not start at that age. It starts actually at the ripe age of 20s, and we'll understand how it progresses. So let us now understand the definition of ISD. What is ISD? ISD is a group of syndromes or spectrum of syndromes that leads to the myocardial ischemia, and it happens when demand surpasses the supply. In a normal cardiac tissue, the supply must equal to the demand of the cardiac tissue. But when the demand is more than the supply, then there is an imbalance, and it leads to the ischemic heart disease. When the demand is more than the supply, then there is the narrowing of the coronary arteries, which leads to atherosclerosis. And the atherosclerotic narrowing is the primary cause between the ischemic heart disease. The other names of ischemic heart disease are thus coronary artery disease or coronary heart disease. So you should remember the basics between ISD, that is the heart does not get enough oxygen to perform its function. Now before we go deeper, let's start learning about epidemiology, because numbers are always wild. So ISD is the number one cause of death, and it's not just in India, it's worldwide. It accounts for roughly 30% of global deaths every single year. One disease and 30% of death. The peak age of ISD is 5th to 7th decade, means 5th decade, 6th decade and 7th decade, that is 40s, 50s and 60s. And males are at a higher risk than females, but only until menopause. And after that the risk equalizes. The main reason is that during menstrual cycle there is one hormone which is known as estrogen, and estrogen is cardioprotective in nature. So after menopause the level of estrogen decreases, and due to which the females become susceptible to the ischemic heart disease. But there is a concerning part that Indians develop ISD almost 10 years earlier than Western populations. 10 years. That is, a 45-year-old Indian man has the cardiac risk profile of a 55-year-old Western man. It is because of the South Asian phenotype. Due to this phenotype, the higher visceral fat and more insulin resistance is found in the Indians, which leads to higher LPA levels. So it is a very important disease to learn and know about from Indian point of view. Let's talk about the risk factors now, because we should know that why people get ISD while some other people do not get. So first criteria is age. The risk of getting ISD goes up progressively with increasing age. Next is sex. Males are at higher risk than females because estrogen protects the females until menopause. Family history. It is first degree relative with premature CAD, meaning before 55 in men or 65 in women. There is a significant independent risk factor. Third is genetics. And under genetics, there are two criteria, that is FH and LPA. In FH, the LDL levels are sky high from birth due to receptor defects. And in LPA, that is lipoprotein little a, which is an independent risk factor that most clinicians still do not routinely check, but it's more relevant in South Asians. So in recent days, there are actually RNA-based therapies in trials that targets LP right now. Now there comes the modifiable risk factors, that is which we can control using drugs. So it's very interesting through pharmacological point of view. First is dyslipidemia, that is high LDL and low HDL. To control it, we give statins. For hypertension, we give AC inhibitors, ARBs, beta blockers. For diabetes, we give metformin, and most importantly, SGLT2 inhibitors. And these SGLT2 inhibitors are cardioprotective. Now comes the lifestyle factors. Under lifestyle factors, there is smoking, which causes direct endothelial injury and it accelerates atherosclerosis. Next is obesity, which drives the insulin resistance, which leads to dyslipidemia, and rest, which drives everything else. Okay, now the pathophysiology behind ISD. It starts with endothelial injury. The inner lining of the coronary artery, the endothelia, gets damaged. Now the question is, what damages it? Smoking, high blood pressure, high blood glucose, basically everything in the modifiable risk factor risk damages it. Once the endothelium is damaged, the LDL, the bad cholesterol, starts sneaking into the intima, the middle layer of the artery wall. And here's the key step, that LDL gets oxidized, and oxidized LDL is the trigger. It is highly atherogenic, and your immune system sees this oxidized LDL as a threat, and it sends in the macrophages. The macrophages engulf the oxidized LDL, but they can't break it down properly, so they just get bigger and bigger, stuffed with lipid. And these are the foam cells, because under the microscope they literally look foamy. The foam cells accumulate, and that's the fatty streak, the earliest visible lesion of atherosclerosis. And you can find fatty streaks in the aortas of teenagers. Now there is one critical distinction between this is why I said earlier that your heart attack started. The stable plaques have a thick fibrous step. They narrow the artery gradually, causing stable angina, migrating up. That's the predictable chest pain on exertion, which is manageable. But the vulnerable plaques, they have a very thin cap and a large soft lipid core. They don't necessarily cause significant narrowing, but they can rupture. And when they rupture, the lipid core is exposed to the blood, platelets rush in, and a thrombus gets formed. And then the artery gets blocked completely, that is MI. So let's understand about the clinical spectrum of ISD. So ISD presents across a spectrum depending on how much of the artery is blocked and how fast. Stable angina. In stable angina, there is partial gradual narrowing of the coronary arteries, so there is predictable chest pain on exertion, which is relieved by rest or sublingual nitrates. The artery here is tight but not blocked. Next is unstable angina. The plaque has become unstable or partially ruptured. There is pain at rest, and there is no troponin rise, no myocardial cell death yet. Here but the troponin on the borderline. Cells are dying, but there is no ST or non-ST elevation. So it is typically partial occlusion. Now is STEMI or ST elevation MI. Here there is complete occlusion, troponin is up, ST elevation, and here this is your 90-minute window. If this 90-minute window is crossed, there will be myocardial ischemia or MI. And here time is muscle literally, and then there will be sudden cardiac death, which is sobering, because sometimes this is the first presentation of ISD, no warning. That is why primary prevention is very important. Now we'll learn that how do we diagnose the ISD. So first to ECG. If there is ST elevation, it will be STEMI. If there is ST depression or T wave inversion, then it can be NSTEMI or ischemia. And pathological Q waves means old infarction, that is dead tissue, has been replaced by the scars. And next is the biomarkers. The troponin I and troponin T are the gold standard biomarkers. They rise at 3 to 6 hours after the MI and peak at 24 to 48 hours, and they stay elevated for up to 14 days. They are highly sensitive and highly specific for myocardial injury. Next is CKMB. It rises around the same time but normalizes by 72 hours, and that is its clinical value because troponin stays high for 2 weeks and you can use it to detect a second MI in the same admission. So CKMB has normalized by then, so a new rise means new. So mainly if we sum up CKMB and troponin, then CKMB is for infarction and troponin is to check for diagnosis. So now let's come back to our 55-year-old patient who is presented to the emergency department with ST elevation. The atherosclerosis in his coronary started when he was in his early 20s, and the fatty streaks started forming silently. A plaque was growing slowly for 3 decades. There was the formation of a vulnerable cap which was thinning over years, and then one night it ruptured and he was admitted to the hospital. Everything that happened in that year, the aspirin, the clopidogrel, the heparin, the decision to take him to the cath lab, every single intervention was targeting a step in a process that started 35 years earlier. And that is why I think pathology and pharmacology are genuinely the same subject wearing different clothes. Once you understand what's breaking down, the drugs write themselves. And if this video has helped you, please drop a comment and do follow and share. It will genuinely help the channel to grow. And this was my first video on this channel. Hope it was good enough.